I'm just going to give a rapid overview of the COVID-19 and Cancer Global Modelling Consortium efforts in relation to cervical cancer, and to acknowledge Freddie as my co-chair in this enterprise. So just very briefly, at the onset of the pandemic, I think our motivation in convening this consortium was really with the recognition that we would need to come together to understand the complex unfolding long-term impacts of the crisis, as well as the short-term impacts. And in relation to cancer control, there's clearly a number of different mechanisms by which the pandemic could either directly or indirectly impact cancer risk. There's clearly, if you think about cancer risk, there's a direct impact, for example, on risky behaviours, as well as an impact on primary prevention programs, clearly including interruptions to school-based HPV vaccinations. Then in terms of diagnosis of cancer, there's disruptions to screening programs and also the potential for delays in other symptomatic presentation. And then in terms of cancer outcomes, there's the potential for direct impact of the infection on survival, as well as the impact of indirect, if you like, treatment, health services disruptions, and the impacts of comorbid conditions. So the interacting and multifactorial nature of these potential disruptions, of course, lends itself and indeed requires modelling to characterise in detail. So modelling is a formal evidence synthesis. The data inputs for the models that we're talking about are many, but broadly they can be characterised as follows. Firstly, we need to understand cancer control effectiveness, and that includes, for example, cervical cancer or HPV-related cancers and their survival according to treatment delivery. In particular, screening effectiveness, and the reach and effectiveness of primary prevention, such as HPV vaccination. We also needed to understand very well the pre-pandemic aspects of how well treatment was delivered, screening participation was occurring, and prevention behaviours had penetrated. So that's what we call the status quo, the pre-pandemic status quo. And then scenarios for timing and extent of disruptions in health services. And all of this is combined in pre-existing detailed and calibrated model platforms for cancer development and outcomes in the population. And of course, once these platforms are available, they can be used to predict a range of outcomes, including cancer incidence and mortality, health services outcomes, costs and cost effectiveness, and health adjusted life years. So what are some of the policy relevant questions? Well, we've been looking at a range of these, of course, starting from just the straight quantification of the impact of the crisis on the status quo. What is the quantified impact of the crisis on cancer outcomes? How does this supplement our understanding of the full impact of the crisis on health, not just the acute impact of the infection itself? Mitigation strategies, what are the optimal mitigation strategies that might be conceivable, and how should finite resources be prioritised? And then, of course, as we talked about yesterday, silver linings. What are the opportunities to achieve better efficiencies in health systems? And what is the potential impact and cost effectiveness of the accelerated option of innovative recovery strategies or new technologies? So very briefly, our consortium has come together. It involves a large number of researchers from many institutions and many countries. And we've organised ourselves into 3 broad working groups. Working group 1 is focused by and large on the direct impact of the infection on cancer outcomes and health services disruptions to cancer. Working group 2 is focused on cancer screening, and working group 3 is focused on primary prevention disruptions. Within working group 2, we've actually split up into several project teams, and you can see here the various collaborators. And we're looking at disruptions to screening programs across the main established types of screening: colorectal cancer screening, breast screening, and cervical screening. And we have a subgroup that's focused on cervical screening disruptions in high-income countries, as well as another subgroup that's really focused more on delays to cervical cancer elimination. And just for your reference, we also have a group that will be looking at delays to lung screening implementation. So on the right, I've just noted the collaborators in the cervical high income group project, and just to acknowledge the co-chairs of this effort, which include Megan Smith, Alexandra Castanon and Emily Berger, who are all speaking at this meeting, and to acknowledge all the other collaborators in the working group shown here. And I just wanted to note as well that the CCGMC has close links with two other key modelling consortia who are also represented extensively today. So firstly, CISNET, which is a US-based NCI-funded consortium of investigators who've come together with a screening focus. So CISNET Cervical has really, I think, moved the agenda forward in terms of characterising the impact of the crisis on cervical screening outcomes in the US in particular. And then secondly, the WHO Cervical Cancer Elimination Modelling Consortium, or the CCEMC, which involves teams from Harvard, from University of Laval with Dr. Marc Brisson, and Cancer Council working with WHO, who've been looking at the quantifying the impact of elimination as we move forward. So the CCGMC has also had, I think, a really important role in starting to coordinate data systems and connections with central sources of data. And Freddie will talk more about the importance of population-based cancer registry information in this enterprise. And that connection with the IOUT team has been absolutely central to the modelling enterprise. But the CCGMC is also working with other collaborators to collate the information that is relevant to modelling cancer outcomes in the crisis. And I just wanted to know, one of our collaborators, Tim Hanna, had a paper out in BMJ last week, which was an important systematic review and meta-analysis, which is informing the modelling. It looks at the impact of treatment delays on mortality outcomes, and importantly, if this is compiling pre-pandemic information on cancer survival, including on cervical cancer survival. And it's a really key source of information that we're using to model the impact of health services disruptions to cancer treatment. So this is a bit of an overview of the timeline of the consortium formation and meetings. But importantly, to note that we came together immediately after the crisis kicked off, really in March and April, and we've I think just now really starting to see the initial outcomes or outputs of the consortium coming through. Of course, this is critically important for cervical cancer at the moment, as we're now the week before the worldwide launch of the WHO Cervical Cancer Elimination Strategy. For the first time, the world has committed to eliminate a cancer, and modelling will be really important, I think, not only to underpin, as it has, the formation of this strategy, but really to, I guess, cope with scenarios that will confront us as we move forward in the crisis. And just in noting this, I think the role of modelling will be key, as I said, in helping us quantify the cost of inaction when it comes to cervical cancer elimination. So today's unfortunate death toll from the COVID-19 crisis on the Johns Hopkins Observatory was about 1.3 million deaths to date in 2020. But of course, we have to compare that with the 311,000 deaths in women from cervical cancer that occurred in 2018, so every year, which is about a quarter of the rate of the direct crisis-related impact so far. And one of the key results that you hear presented today is the first estimate of the cost of inaction from Kate Sims, who'll be presenting some initial results on that to really quantify what it means every year that we are forced to delay our action in terms of elimination and the scale up of the key interventions. The other aspect of elimination of the consortium activity, of course, is really helping to support the evaluation of new interventions and innovative approaches, the silver linings from the crisis. And we all know about what was Project Rose, now Program Rose in Malaysia. A key example where modelling will help support the rollout of similar innovations involving HPV self-collection, HPV testing, and the use of secure mobile digital platforms in a way that will allow screening scale up in an innovative fashion as we go forward. So just to finish and to acknowledge all the collaborators and all the speakers today. And that's an overview of some of the important work that you will hear about in the rest of the session. And I would